It is just an honor to be in Tel Aviv, Israel, with the, what is your title? We would call it the dean of the dental school.
No, it's the head of the school.
The head of the.
We are part of the medical faculty, which consists of 4 schools. One of them is the dental school. So we are a school, and I'm the head of the school since October this year.
The head of the dental school?
Head of the dental school. Actually, I'm a graduate of this school. I graduated in 1986, and since then I remained in school as an instructor, and then as a lecturer, and then I became a professor, and I'm now heading the school in which I graduated. And actually, I'm the first graduate student who is heading the school.
Oh,
the head
nice.
of the school.
And your name was Shlomo Matalon?
Shlomo Matalon is my name.
So does that mean your nickname was Shlomi?
Yeah, right.
Shlomi?
Right.
Okay,
right.
because we podcasted a Shlomi yesterday, and he kept going back from Shlomi to Shlomo. So
well, it depends. My close friends call me Shlomi. The others are, official name is Shlomo, but mostly people call me Shlomi.
So, well, I would love to hear the story of the university.
It's the story of the school. The school was established in 1977 as a school for those students who studied abroad, and for those dentists which were not really dentists. They didn't graduate dental school. It was some kind of a dental technician who could treat people, mostly from Eastern Europe. They came from Eastern Europe. So in order to elevate their knowledge, the school was established. And he accepted students who had 3 years of medical studies behind them. So it was a 3-year school for those who studied already 3 years of medicine. I came to the school in 1983 after 3 years of medicine in Germany. And since then, at that time, the school was supported by the government and by one of the HMOs, the biggest HMO provider in Israel, Kupat Cholim, Klalit. And as a graduate of this school, after our graduation, we had to go to work in one of the cities in Israel according to the needs of the population. It could be in the north, in the south, in the east, in the west. And these are all where the clinics were or are in Israel. And we had to serve there for 2 to 3 years. That was a very good project because we could supply good dentistry to remote located population, and the population with the low income who couldn't receive a good dentistry at that time. So this was till 1992. In 1992, this HMO stopped the project, and at that time we actually started a 6-year program as well. So a student who came to this school had 6 years ahead of him, and when he finished the 6th year, he got the DMD degree. It was a school of 6 years. And unfortunately, at the beginning of this millennium, the school was in a very bad situation, economical situation, and the university intended to close the school. In 2000, and actually we almost didn't accept students to the school. In the 2010, the government decided that the school must exist because there are only 2 schools in Israel, one in Jerusalem and one here in Tel Aviv, and actually forced the university to reopen the school. So the school was reopened in 2010, and since then, the school has changed a lot. First of all, the university started to invest in the equipment and in the program of the school, and we start flourishing in a way. Now we are in a position in which we have almost all postgraduate programs here in the school. We have special clinics for people with special needs. We have operation rooms for general anesthetics for people who need general anesthetics. We do treat children with special needs as well. And we do treat people from a low income population, which they don't have actually where to go, so they come to the school. They do pay something, just a symbolic payment for their treatment, but we do hear everything under one roof. So if somebody comes with simple things in dentistry, so he gets treated by the students. If it is a very complicated or more complicated case, so he goes to the postgraduate students. So everything is treated here, from the very simple treatment to the most complicated cases who needs, for example, orthodontic surgeries and the other treatments. So the variety of what's going on in the school is great. But still, we do need, to enlarge our activity. We want to reach other populations in order to bring them to the school. The elderly people, we would like to have them here in the school as well. They do come, but since there is a law now in Israel which covers the elementary dental treatment for children between the age of 0 till the age of 18, and elderly people from the age of 75, they can treat almost for free in the different HMOs which are existing in Israel. We have 4 of them. And that actually cut the population who came to the school. This is a problem, but I think we will overcome on that problem with an agreement with those HMOs that they will send us the patient. We will treat them instead of their dentist, and the population and the state will benefit from it. First of all, the population will get the treatment, and second, the students who are going to be the next generation dentist can practice whatever they will need in their daily life afterwards. If they will not treat children, or if they will not treat elderly people during the studies, how would they treat them when they graduate? That's a question which is now should be answered. And hopefully it will be answered positively by sending these patients to us. But besides treating people, we do have a center of research here at the school, and we are very proud of our publication. The research which is done here is quite novel, and it is published in very high-ranked journals. So we are proud of that as well. So we have the clinical part and the research part, and the combination with these 2 giants makes the school even better. What I forgot to emphasize is that our school is one of the very first dental schools which went digital. Our students do everything digitally. They hardly take impressions anymore. They scan everything. They mill their crowns here. They give the patients, the crowns or the bridges in time span of hours. And that's really prepares them to the real world, because now dentistry goes digitally, and everything is done digitally. Even implantation placing implants is done digitally. So we are one of the first schools in the world that our students studied just from the beginning to work with scanners. Even in the Phantom Lab they do that, and of course in the clinic. I would love to take you afterwards upstairs and show you.
So
the
did
clinics.
they start crying when they found out they never got to wax up a crown and cast it again? That was
Anyhow, you know that. By the way, the digital dentistry actually improved the quality of dentistry, because now when you take an impression, when you took an impression of a tooth, I mean, you could hardly see if it was really, really good or bad. Now when you scan and you see it 10 times bigger and you see it on the screen, first of all, you can correct it immediately. And second, I mean, you can see the quality of the preparation much better. So it elevates the quality of dentistry that we provide. And I think it is very important.
magnification is the key to quality. Whether
Right.
you wear loops, whether it's
Right.
endodontics,
Microscope,
whether it's digital. So I notice every country has a different number of specialties. How many specialties are in Israel?
We have 7 specialties.
7?
We have in orthodontics, we have in endodontics, we have in pedodontics, we have in oral pathology, dental medicine, we call it as well, and surgery. Did I forget anything?
But I want to go back to dental medicine because that's kind of an interesting history in dentistry. Some countries, physicians and dentists are much closer together. They might be MD, odontologist. And then in some countries like the United States, they're more separate. And you said that you now have a government program for elderly over 75.
Right.
Now that was just recent though, wasn't
Right.
it? Yeah.
It started only in October.
Yes, and so like in the United States, the local states help children, that's Medicaid, but the national Medicare, they don't cover teeth, as if the teeth weren't part of the human body. And now you have especially dental medicine. So do you see the future where dentists and odontology gets closer to MDs and medicine? And because you were even saying the HMOs that provide the deal, that's a hospital organization.
It is a hospital. It's a dental hospital. What we have here is a dental hospital, and I think they must go together, because elderly people normally come with the different kind of diseases and illnesses. Well, I wish that everybody was healthy, but some blood pressure or heart diseases, and they should be treated differently. And physician and dentist must work together. And we do have a department here at the school, but it is connected directly with the departments in the hospital, in the nearby hospitals. So they do work together.
And that's a specialty, dental medicine?
Dental medicine is a specialty.
Will you explain that, go into more detail on that, because that's a new one.
Dental medicine is those people treat people with the how they say, with different diseases that needs to have special care. In a way, it's a special care clinic. If somebody cannot be treated by general dentist for some reason, he had cancer and had radiation in head and neck area. The extractions cannot be done either only in a surgery room and with a special treatment. A different case is people with Alzheimer or people with Parkinson. They should get the dental treatment in a different way. So those people who are specialists in dental medicine, they are specialized and they are taught to be a dentist who treat these special care people. So that's line in medicine, in dentistry, which is focused on the special care people.
And how many students are in your class size?
We started, when I was a student, we started as 24 students per class. Now we are heading to 70 students per class. And the system here is starting 3 years ago, that the students work in pairs. One from the fifth year, and the two last clinical year, the last 2 years are clinical years.
Out of 5 years?
Out of 6 years.
6 years. So you leave high school, 12th grade? And
We
then,
have high school, we have the army normally for 2
Okay.
to 3 years.
Okay,
And then
so-
they enroll to the dental school.
So how old's the average freshman? Probably 20 to 21?
21, 22, some go after their army service abroad for a year, but it's around 21, 22.
And then it's a 6-year
And
program.
a 6-year program, and they graduate when they are 27 or 28.
And what year did this school start?
77.
77?
We celebrated almost 42 years already.
And then the other dental school is in Jerusalem?
Is in Jerusalem.
And that
They-
started
years ago,
52?
in the 50s, in the 50s, and they had their 6-year program starting from the beginning. We were a little bit different.
And what is your biggest challenges taking 75 kids, babies that are 21, 22, and 6 years later giving them a license to turn them loose on society? What are your biggest challenges?
Listen, the school is known for its best graduates clinically. We are very good clinicians. The graduates of Tel Aviv Dental School, they are known in Israel as very good clinicians because we practice a lot. And they have to practice a lot. Our clinical requirements are quite high.
Would you mind saying what they are?
Like 18 crowns they have to do. They have to do at least 2 crowns on implants. They have to plan the implants. They have to do the casting. They have to do almost everything. At least 120 fillings. And
are those fillings all
18
composite or amalgam?
No, amalgam. We still use amalgam and composite as well. And some are inlays and onlays. They are required to do at least 4 or 5 onlays and inlays in their studies. They have to do at least 2 pairs of dentures, which we are now in a bit of a problem with these elderly people who go to the HMOs. Hopefully they will remain in the school. 18 root canal treatments. So they are really, our requirements are higher than in Jerusalem.
So, an interesting observation of Israel for me from the United States is it seems like almost every dentist places implants. A lot of dentists place them compared to the United States. So some countries like Korea, Israel, Brazil, maybe 1 in 4 dentists placed an implant last month. In the United States, that might only be 10%. Why do you think so many dentists in your country place implants more so than other countries?
First of all, we have a lot of dental implant companies here in Israel.
How many do you think?
I don't know, but tens, I think.
What would you say? At least 30?
At least, I mean, yeah.
We have about 12 manufacturers, and we have about 60 companies.
So 60 companies sell implants, but only 12 are the original manufacturers?
Yes.
So they manufacture for some of the other companies?
Yes.
And they are well known in the world. It's not, a very small company which supplies only the needs of the country. Most of the implant producers are exporting, and a couple of very well known companies are Israelis, and even a couple of them were bought by giants.
MIS?
MIS, Alpha Bio,
Alpha Bio?
which was bought by Nobel Biocare, a very known
And
big
who was
company.
who was MIS bought by? Noble Biocare too?
No.
MIS
is by
Dentsply.
Sirona. No, by Sirona. Dentsply.
Dentsply
Sirona.
MIS, Alpha Bio, Noble Biocare.
Right.
And what was the third one?
And now Paltop with Keystone.
Paltop,
Paltop.
Keystone. So why do you think that is? Why did this country spawn so many implant companies?
We are the startup nation, as you know. We are known as a startup nation. So some good ideas were invented here. And the proof is that our implants, or those companies' implants, were bought by other companies. That means that they are very high quality and they are innovative. So that's why Israel is known for its implant. Dentists do place implants here, I think because they want to control their work. If you send the patient, for example, to a surgeon to place the implants without a jig, so either you get it where you wanted the implant, or you get it a little bit further, or not in the exact place that you wanted it to be. If you do this by yourself and you know that you have to restore the implant, you most probably would put it in the right place. I don't see.
I want to go in a different direction. One of the things in America that I find absurd is that 8.5% of emergency room visits are odontogenic in origin, and for the most part, they'll just give them antibiotics and pain meds.
Mm-hmm.
So if I go into a hospital with a broken leg, they can fix it. A tumor in my brain, they can fix it. A heart attack, they can fix it. But I have an abscessed tooth, and they give me PenBK and an opioid. And we don't have a specialty dental medicine. And then when you talked about DSOs in America, not one of them is associated with a hospital. And here, you have a specialty dental medicine. Your DSOs are associated with a dental hospital.
Right.
I don't think there's a, quote, dental hospital in America. So I wish you would explain to the dentist more how your DSOs are connected more to a dental hospital or an HMO. And maybe that's a solution going forward. I mean, I've always advised DSOs, if I was going to start a DSO in America, I'd put one in every emergency room in America. If 8.5% of the people walking in have a toothache, what better place to be?
Yeah.
So why do you think you got a dental medicine specialty? Why do you think your DSOs are connected to a hospital? And why do you have dental hospitals?
We don't have dental hospital. I call the school dental hospital because it has everything what dentistry needs, or all field of dentistry are done here, almost. Why almost? Because orthodontic surgeries we don't do here in the school. We do it in the hospital, because people cannot stay here overnight. We don't have overnight possibility here to control or to supervise the patients. So that's why we are connected to hospitals which are close to the university. We do have good. There are over there in the hospitals. There is a department of oral surgery. In all these hospitals, there are departments of oral surgery, and we send our students to these departments in order to see things which are not done here in the school. The question of dental medicine, or what we call specialty in dental medicine, is to treat people, as I said before, with special care, or they need special care, or they are in a very, from the medical situation, they cannot be treated in a normal dental office. HMO, even the HMOs, they send us people to be treated here instead of sending them to the hospital to be treated. So we have very good connections with the HMOs, the different HMOs, concerning these people, these patients who need special dental care.
You also have a rich history with a dental fraternity.
Yeah, with Alpha Omega.
Yeah, let's talk about that.
Well, Alpha Omega was one of the establishers of this school and supported the school since then. I mean, without this fraternity, I don't know where the school could reach. Alpha Omega supports us all along the way, in our good times and our bad times. And whatever you will see here in the school was donated, or most of the things here in the school were donated by Alpha Omega fraternity, or actually, yeah, I could say almost everything here, because some equipment were donated by the Alpha Omega in the States, but some in Alpha Omega in Canada or France, but it's still the same fraternity which supports the school, I mean, remarkably, really remarkably. At the bad times that we had at the university intended to close down the school, some of the Alpha Omegan who are in or were in the board of the university actually convinced the university and put a lot of pressure in order to stop this closing. And finally we are here, and we are sitting here, and we are talking. And
so I believe America has 56 dental schools, and I think 5 of the deans are graduates from Israeli dental schools.
Right, which means that we don't have such a bad dental schools, I think.
Yeah, so were you aware that there were, I think, 5?
I think 5, at least a couple of them I know personally.
And some are extremely prestigious. I mean, the dean of USC, that's got to be one of the most prestigious dental schools.
Yeah. Right.
So,
and
rich
in
dental.
Cleveland, in Cleveland, we have Eli Eliav, Professor Eli Eliav, who is the dean over there, and we are proud of our dentists, and we are proud of them. They are really great ambassadors to Israel, and we talk to them. I know them, some of them personally. They are good friends of mine, and they really help the school. Not money-wise, but academic-wise, and some good advices.
So do you still have the old-fashioned textbooks, or is even that going digitally?
Everything digitally goes.
So they don't even. So
for example, we have lectures. We do.
But do you have?
But most of our lectures are by videos.
Yeah.
They go by Moodle. Textbooks are existing, but
do you think they'll soon go extinct?
The textbook was written 5 or 6 years ago.
True.
Everything now is, you want things up to date.
It takes 5. It takes 5 years to even write the textbook, and then they use the textbook for 5
They're not
years.
relevant. The textbooks are not relevant anymore. Oh, I cannot say not, but they are less relevant. Now everything is everything you can find on the internet, PubMed, articles. It's not the same way that I was taught. I was taught to learn by heart things and to know by heart things, and we teach them to think. We give them the basic, but we teach them to think. And if they know the basic and they know how to think, they can be a very good dentist, and they practice a lot. They can be.
So we call our podcast Dentistry Uncensored because we like to talk about everything that people argue about. We don't want to talk about anything they agree on. One of the biggest controversies in America is the treating pain with an opioid after a root canal or a surgery. Is that a big issue or controversy in Israel?
No, it's not. No, it's not. It started to be, but it's not. And as much as I know, Israelis are not very big consumers of opioids, are not.
Of what?
Of painkillers.
So opioid abuse is
Okay.
what do they call it?
Opioid.
Yeah, they used to call it substance abuse. Now they call it substance use disorder.
Mm-hmm.
So opioids isn't a big substance use disorder
No,
in Israel.
it's not. It's not.
But if you were going to pull my 4 wisdom teeth
Mm-hmm.
after the procedure, what would you give me for pain?
Just Optalgine or something which is very light killer. It's a painkiller.
Like what?
Which we call it Optalgine or paracetamol.
So acetaminophen.
Acetaminophen. Yeah, nothing which it shouldn't.
Not an opioid.
No, normally not.
Normally
not.
And
even in antibiotics, now is the tendency to shorten the time of antibiotic treatment. So we do that here as well. Not everything.
So you usually don't prescribe an opioid after a root canal session.
Normally not.
Another issue, I call it the aesthetic health compromise.
Mm-hmm.
It seems like I got out of school in 87. You graduated in
86.
86?
Yeah.
My gosh, and when it seems like dentistry was better back then because all the fillings were amalgam and they lasted, they're metal. Every ingredient's antibacterial. Gold crowns cemented with zinc phosphate cement. And then we had the aesthetic revolution where everybody said, oh, I want it tooth colored. And they replaced that metal amalgam with a inert plastic, which is so ironic because the research shows they last maybe 6.5, 7 years, but every dentist you talk to thinks his lasts forever. Mm-hmm. And so is that a challenge for you here, switching from amalgam to composite?
It is a challenge because there is no right or proper replacement for amalgam. That's my opinion. And from my 33 years of practice, I do see my amalgams still in most of my patients that I did when I was a student, and I see less composite restorations who survived this period of time. Amalgam is fading out. That's by the Minamata Agreement, and in some countries in Europe, they don't allow the use of amalgam at all. For example, in the Scandinavian countries. And Israel is following the European, the European law, and slowly it fades down the use of amalgam. Whether composite is the right choice for the time being, that is the only choice that we have, or inlays and onlays from lithium disilicate, for example. But not everybody can afford inlays and onlays. And so the cheapest solution is composite. Composite has improved during the last couple of decades, but it still has its drawbacks. And it's a very aesthetic replacement, but whether it's a replacement for amalgam, I doubt it.
Well, Raphael, we talked to a company. Talk about that company.
We met with a company called Nobio. Nobio has developed a composite that is antibacterial properties, and this will allow to solve this issue. And it's really new company.
How close or how promising is it? And have you seen the material? Do you think you will be evaluating it or looking into this?
Yes, of course. I mean, one of the problems of composite resin restoration is that they leak. And whenever there is a leakage, bacteria and the saliva can penetrate and start the action of caries. And if you have a material which can stop the action of the bacteria, like a material which is antibacterial, so it won't overcome the problem of shrinkage and leakage, but it won't allow the bacteria to proliferate and cause damage. So it's quite renovating material.
So you have seen it?
Yeah, I've seen the material.
And
We have tested it in the school as well. And I know that the results were very good. We tested it in vitro, not in vivo. I mean, not on patients, but on in the lab. And it looks really promising. It will do a little, I mean, not a little, but it will make a change. It will improve the composite.
When do you think it will? You'll start human trials?
I don't know. I'm not in the company, so I don't know. But I know it got the FDA approval. The composite have passed the FDA. So I think if it passed the FDA, it should have passed the clinical trials.
And then the European equivalent of the FDA is the CE mark.
CE mark.
Is it CE mark?
CE mark.
CE mark. What does CE stand for?
Your community, European community.
Okay, so it's passed the CE mark and the FDA?
I think so, but we're going to meet them tomorrow. So.
Yeah, that's exciting because I've always thought dentistry, a good analogy was like you build this beautiful barn out on your farm and you tell everybody to brush it and wash it and clean it every day. But at the end of the day, it's eaten by termites. And you listen to dentists talk, their language is like engineers. They build bridges, but it's really more biology. Our restorations are eaten by unicellular organisms and fungi and eukaryotes and prokaryotes. So I always thought dentistry is more a game of biology than a game of civil engineering.
I think it's a combination.
True.
If you don't have the engineering knowledge, it's very difficult even to build a simple or to understand how a simple bridge stands and what kind of forces it should absorb and the direction of the forces. I think dentistry is a lot of engineering, and of course, as being medicine, after all, it's a lot with biology. So it's a combination of biology and engineering.
Well, I think more fillings fail because biology, recurrent decay,
that's true.
than structural.
That's true.
So I'm really excited about tooth-colored restoration getting an active ingredient that's antibacterial.
That's the Nobio.
Is what we've been after since the aesthetic health compromise of switching from amalgam. And it's so bizarre because gold, like all the women here have gold rings and gold earrings, but they won't put them in the teeth. I have 7 gold onlays in my teeth, and I can't get anybody in America to want to do that. While they have a gold pin in their nose and gold earrings and gold jewelry. So they really want tooth colored. So tooth colored restorations really need an active ingredient.
Yeah, it does. I agree with you. As long as it's composite resin, which shrinks. Maybe one day they will find a material which is antibacterial and its physical properties are a little bit better than the composite, so it will overcome even the problem of shrinkage.
Wouldn't it be nice if you could get one to just slightly expand a 0.5%?
Maybe it's even better.
Yeah.
It's much better rather than shrinkage of a 0.5% or 5%.
So is there anything that you wanted to talk about that I didn't ask? Or any other?
I think we concluded or we went over the program of the school, the aims of the school, the targets, the challenges, and our graduates.
And how long have you been in charge here?
2 months.
2 months?
Yeah,
Congratulations.
Starting in 1st of October.
Congratulations.
Thank you very much.
Was it scary and overwhelming or?
Well, as I told you, I'm here in the school. Actually, it's my first house. I'm spending here more time than I spend in my home. And that was since 1983, when I entered to be a student. So at that time, I spent 80% of my time here in this school. But since then, I was always here, so I knew what I'm going to. And it was not a surprise, or it's not overwhelming. It's a hard job to do, and it should be done. And I have to continue the great job, I must say, that my previous heads of schools did. And I hope I'll be able to fulfill the wishes and the challenges which I
Last and final question. This is the most controversial. Dentists have so many years of college. They all are so opinionated. It's so hard to get them to all agree. I mean, like, if you go to the American Dental Association, you couldn't get 10 dentists to agree that today is Wednesday. So how do you, as a leader, get so many strong, opinionated dental minds to all agree to think and go in the same way? Would you say getting dentists all on the same page is always going to be the hardest challenge in any dental school?
I don't think so.
Really?
I don't think so. I think it depends on the personality of the leader. For example, when I entered the school, I told to the heads of the departments that for me, they are the board of governments. I am just the CEO. So they decide. I will raise the problem. They will decide, and whatever they will decide, I will execute. In that way, even if somebody does not agree, if and he is a minority, he's still accepted because he was involved in the decision. And bringing the people to be involved in the decision make them very cooperative, even if they don't agree with the result. And since most of the heads of departments here are my good friends, since I spend with them a lot of time, and that's the way I run the school. So it's quite easy.
One last question. Raphael has been trying to explain to me DSOs connected to HMOs, and she's been having a hard time. Would you want to ask the question, or?
HMOs are organizations who provide health to their members, actually. Dental care, and general care. Everybody in Israel must be a member of one of the HMOs.
Oh, okay. I didn't know that.
It's obligatory. You cannot be independent.
Every dentist?
Every citizen.
Every citizen.
Every citizen, not a member, not the dentist. Every citizen has to have an insurance, health insurance, but in one of the HMOs.
And there's 4?
5.
5.
As much as I recall, Maccabi, Klalit, Leumit, Mouchedet, 4, right. If I haven't forgotten anyone. And so everybody's insured. Now, dentistry was not is not covered by the government, or was not covered by the government. Once it was covered by the government, children from 0 to 18 and elderly people from 75 to 120, the state gave these HMOs the possibility to treat these people and to get refunded by the government. Besides, these HMOs opened their own clinics, dental clinics, which are actually private companies owned by these HMOs. And they provide dentistry to everybody who wish to come. Their members are getting discount, but they are treating everybody. So they are a competition to the private sector. Each and every one of these HMOs have some sort of a company or partnerships with a dentist or they have their own dental clinics. And some of them are really wonderfully equipped. And most of our graduates, when in the first years of practice, they work for these HMOs. They don't open right away their private clinics. Still, the majority of the population of Israel is treated by private dentists, but slowly, it goes, the HMOs are getting more and more patients. That's about the HMOs in Israel.
It has been an honor and a privilege to podcast you. Thank you for making time.
I'm honored to have you here, and I hope you have a nice stay in Israel and you enjoy your stay in Israel, and hopefully it will be fruitful as well.
It's been fantastic, Raphael. It's been very good, very good. Thank you very much.
Thank you.